All right. Well, good afternoon, everyone. Thank you so much for joining us. Welcome to today's community webinar, jointly hosted by Parent Project Muscular Dystrophy and the Muscular Dystrophy Association. My name is Rachel Schrader, and I serve as PPMD's Vice President of Clinical Care and Education. We're happy to have you join us today as we discuss both consensus recommendations and considerations for the delivery and monitoring of gene therapy and the newly created Comprehensive Family Guide for Gene Therapy for Duchenne Muscular Dystrophy. As a reminder, today's webinar is being recorded and will be available for playback in the coming days. We also look forward to answering your questions at the end of today's webinar. Please feel free to submit your questions through the chat function, and we'll address as many as possible during the open Q&A session at the end. I'm joined today by two expert physician leaders who will guide us through the creation and key messages of these companion documents. Dr. Barry Byrne is the director of the Powell Gene Therapy Center at the University of Florida, and Dr. Diana Barucha-Goebel is the medical director for the Gene Therapy Center for Excellence at Nationwide Children's Hospital in Columbus, Ohio. Additionally, I'm joined by my colleagues from MDA, Nora Capocci, who serves as MDA's Executive Vice President of Healthcare Services, Marissa Lozano, the Director of Community Education, and PPMD's Katie Jasonic, who is our Manager of Clinical Care and Education. The landscape of treatments for Duchenne muscular dystrophy are complex and changing rapidly. We're grateful for a deep pipeline of approved therapies, including 8 approved drugs, with many more in that pipeline. With this, we recognize that there are many questions from the community regarding eligibility for certain medications, details around the initiation of those medications, and the use of multiple approved therapies, and what to expect during the screening, treatment, and follow-up of these therapies. During today's webinar, we look forward to a conversation into the screening, dosing, and follow-up of gene replacement therapies in Duchenne. The resources developed and presented today were created with this rapidly evolving landscape in mind. While these resources are intended to be product agnostic, that is, applicable to all gene therapies and not one specific product, we do want to acknowledge that one such therapy, Elevidys, is available commercially for ambulatory patients age 4 years and older. Additionally, there are several others that are available through the clinical trial setting. We hope that these resources are a useful tool for providers, patients, and families. With that, I invite Dr. Byrne to join us as we start today's discussion. Dr. Byrne?
Thanks very much, Rachel, and welcome to everyone who's online to go over this important topic. Just about 2 years ago now, a group met as part of a safety meeting that was being held by MDA, and ultimately, really in an outstanding collaboration, further met at a PPMD meeting and assembled a group of experts that had some experience in the context of the clinical trial use of various products that, as was said, the intention of this guideline was to be generic about the considerations for the use of gene therapy. And we met over the course of this last 2 years to develop what we felt was the most comprehensive considerations for the use of gene therapy products in the context of Duchenne. If you can go on to the next slide. What I wanted to do during my period, and then I'll turn it over to Diana, is just give a very brief overview of fundamental aspects of gene therapy, which highlight an important aspect that leads to safety considerations. Talk about the publication and how it came about and how we reached these consensus recommendations. And then we'll discuss the family guide that is going to be released imminently. So if you go on to the next slide. AAV gene therapy given systemically requires that the vector bind to a cell surface receptor. And if you can just step through these steps, that would be great. The vector goes inside the cell. And of course, to get the level of an amount of vector that reaches most cells, the exposure is quite high. Those vectors go through a pathway called the endosome, where the vector ultimately reaches the nucleus, where all the instructions for making proteins are maintained, and the vector DNA is released. Ultimately, that DNA leads to transcription that produces a therapeutic protein. Um, all these steps impact the efficiency and again influence the dose, which is something that has been a concern about managing the safety events that are associated with those higher doses. But ultimately, the goal of these stable extra episomes within the nucleus lead to continuous expression of a therapeutic protein. And just in the context of the commercial product, as it was mentioned, if you go to the next slide, I'll just highlight the parts of this. All gene therapy vectors rely on a capsid protein that surrounds the DNA. That is how the DNA is protected as it reaches the cell and the nucleus. In the case of delandistrogene moxeparvovec, that AAV type is called RH74. There are now many versions of AAV that have been developed through directed evolution, and a series of additional ones that are in the same generation of RH74 that have been in development or in clinical studies or anticipated to come to market over the coming years. This vector delivers the microdystrophin gene to cells. This was mentioned, the only approved product to date, and it relies on the expression of the therapeutic transgene from something called a promoter, which in this case restricts the expression to muscle cells. It also includes an enhancer element, which is intended to improve expression in cardiomyocytes. I think the reason we're specifically highlighting this is that the majority of the experience worldwide, really over 1,200 patients, is using this product SRP 9001, which became known as Elevidys once it was commercialized. And at last year's MDA meeting, there were reports from Sarepta that looked at long-term functional outcomes, 2-year data from the EMBARK study, and the totality of the evidence that had been achieved so far. So this was the anticipated marketing launch of this was what prompted this group to begin to discuss what their own individual institutional experiences were and to develop this comprehensive care guideline. If you go to the next slide. After about a year of drafting and revision with outstanding support from MDA and PPMD, we assembled this publication, which was recently published in Neuromuscular Disorders. And I'll just highlight how we broke down the components of this so that we can get into the discussion of how this is now implemented in the real world. So if you go to the next slide. One of the most important things I think as a group we realized is that it was important to have a multidisciplinary team. This is the underpinning of both the care center network that MDA supports, as well as these care centers certified by PPMD. It requires institutional experience with a core team that's shown here, multidisciplinary care. Is not only required for continuity of care of boys with Duchenne, but certainly in the context of treatment. Given that the safety events that have been identified both in investigational use and commercial use of this and related products requires rapid access to laboratories and in fact in real time to be certain that we can identify the safety events as they're evolving. And then of course, to get commercial authorization requires a team within the institution and particularly within the pharmacy group to lead to market to get the prior authorization request approved in a letter of agreement to authorize this very expensive therapy. The next slide. Then we really looked at how do we identify patients, evaluate them for eligibility. This is a very detailed description of this aspect because this therapy is not appropriate for every patient. We want to confirm their genetic diagnosis, make sure that they have not a mutation that has been found to enhance the likelihood of myositis, so those are excluded. We have to establish their eligibility based on antibody testing, which is a whole other topic. And that's listed here as what we would call the exclusion criteria. So specific mutations are excluded. And now we know that underlying liver dysfunction can be a problem, and those with low cardiopulmonary function may be at increased risk. And so next slide. Then we have to get prepared. So baseline assessments are part of that. At least at our institution, we feel that it's important to have baseline cardiac MRI. Many boys now have this routinely as part of their annual evaluation. So this is within 6 months of the treatment. That's sufficient. We confirm the level of pulmonary function as well as baseline time function tests. And then if they're on an alternative form of glucocorticoids, the only known pre-treatment regimen that has been the most successful in this context is with conventional glucocorticoids. So we may have to switch back to those therapies. Patients undergo informed consent, and then we have a treatment plan that specifically outlines the really important follow-up events that occur in the days and weeks after the treatment's given. Next slide. So then there's the all-important treatment day. We are at least mindful of the timing of when there is a need for increased monitoring. So we always avoid midweek, for example, so that those critical events don't fall on the weekend. We set up a schedule, pre-reserve the infusion area, and at least at our institution, I think this is increasingly being organized at other sites. We have a dedicated area that's specifically configured for following gene therapy patients, and it can also allow for 23-hour stays if needed after the treatment is given. And this, of course, requires patients to be in the vicinity of the treatment site for quite some time, and Diana will touch on that in the next section. And then as part of long-term follow-up, if you go on to the next slide, we have a schedule of events that is not unlike participating in a clinical trial. This was not required in the original prescriber information, but we felt it was important to track some of these laboratory parameters more very carefully at a higher frequency than was in the original label, particularly for a longer time beyond the first month. And then based on that monitoring, with also recommendations from the Action Network, it was then possible to really hopefully enhance the safety of this type of treatment. Next slide. And then that leads into long-term monitoring. So beyond 3 months, how do we determine the ongoing efficacy? And in fact, there's an effort underway to look at some proteomic signatures in treated patients, which would be informative as well as the functional outcomes. And then the ability to report in a real-time fashion any adverse events into the FDA database called the FAERS or FAERS long-term safety data has to be collected in a centralized site, as well as in registry like Endure. So that's the high-level summary of the publication. We wanted to make this more accessible to the all caregivers and those with Duchenne, and so Diana will talk about how that has been done with the work at PPMD and MDA to develop a lay summary.
Thank you. All right, so next slide. Thank you for being here. And I also just want to also acknowledge MDA and PPMD for helping to bring together the group of clinicians and researchers who helped in creating the initial consensus guidelines. And also, again, acknowledge all of them for the input that went into developing these and thinking about how we all practice to try to ensure as best we can the closest follow-up for safety and the best outcomes for the patients and children and families for whom we're considering gene therapy. So the goal of the family guide, as Barry mentioned, is to really help our patients and their families to understand the current consensus guidelines and recommendations for gene replacement therapy for Duchenne. We want to help in doing so to empower our families and patients to make these informed choices about gene therapy, and also to make sure and to improve that awareness of the kinds of risks and benefits that one might expect or should be thinking about with gene replacement therapies. And hopefully, in understanding some of these, that can also help for families in thinking about the kinds of questions they should be asking of their healthcare teams when thinking about whether an approved or also potentially clinical trial-based gene therapies are right for them. Next slide. I won't go over this again, but because I think this was already well described in the introduction of what is gene therapy. The only couple points just to highlight again is that, as Barry mentioned, the what we're using here to deliver the gene, which in this case is a shortened version or microdystrophin, and each product by different sponsors or different companies might be slightly different, but have some very core elements that are needed for function. But it's given using an envelope or these AAV capsids. These viruses help, again, shuttle or get the microdystrophin, this transgene, to the cells where they need to be delivered, for where they can then be transcribed, translated, and basically produced into the protein for function. And it's given again one time through an IV infusion, and once it's been dosed, you cannot remove it. So similar to thinking maybe about a transplant, that is what makes gene therapy quite unique in many regards than other therapies that you might consider. If you're not tolerating it, can you just stop it? And so we really go into this trying to make sure we understand those safety risks and also prepare for it with some of the medications we use in terms of immune suppression, and also the labs and other studies to make sure that as best we can try to understand if somebody is is a good candidate to try to decrease the safety risks. Next slide. So when we think about eligibility, these really tie into trying to make sure that we are dosing individuals who have both the best prospects for benefit, but also ensuring that we're not going to run into major safety concerns or issues. And this is still being evaluated, and there may be strategies in the future, certainly, where we try to overcome these further. But at this time, we do have criteria based on genetic variant. So for the approved therapy for Elevidys, this does require that we do not dose patients who have exon 8 and or 9 deletions due to the risk of a sort of rejection or an anti-transgene immune response. Different sponsors may have slightly different exon deletion criteria within their guidelines and within their protocols. We also, there are criteria based on something called antibody levels. So these are looking at particular immune cells in the body. So whether you have antibodies against the AAV serotype or capsid, in that case, that's being used. High levels could pose a higher safety risk, and also might mean that those that the AAV is actually cleared before it really gets effectively to enough of the cells that we're trying to get to. There are also potentially eligibility criteria, both for the current approved therapy, but also in clinical trials based on function. And these may be different for different products because they're going to take into account both risks and benefits, what's being explored maybe in a clinical trial, or in the case for Elevidys, it's currently based on the label. It is approved for 4 and older, and in individuals who are ambulant right now. There's also mention about vaccinations. So we want to try to decrease the risk of additional immunogenic exposures, things that can rev up our immune systems before or after receiving gene therapy, which is already going to be kind of a stress to the immune system overall. And so for example, in the current label for Elevidys, it does list, and based on the consensus guidelines as well, lists that vaccines should be, you should avoid giving vaccines at least 4 weeks prior to gene transfer for safety. The caveat being, of course, though, we want to ensure for best safety, we do want to make sure children or individuals rather who are receiving gene therapy overall are up to date on their routine as well as seasonal immunizations. And then lastly, we look at many safety parameters, but especially we want to look carefully at baseline heart and liver function to ensure that in the event that someone has more advanced heart disease or signs of any liver impairment or dysfunction, we don't want an increased safety risks in that, especially the heart or liver may not handle the stress or inflammation that can naturally occur after gene therapy, as well as those without perhaps more involvement or more advanced disease. So those are some of the key parameters that go into eligibility considerations. So for families, an important thing that as you're thinking about gene therapy, we have in the consensus guideline and also in the what will be in the family guideline, how do you think about selecting a treatment site? It should be, as Barry mentioned, it should be given in hospitals or specialized centers who have both experience in the delivery of AAV-based gene therapy and also have the experience and availability to manage complex DMD-related care. This means having that multidisciplinary team. So you are probably mostly familiar already with that multidisciplinary team, seeing the neuromuscular team, the cardiologist, the pulmonologist, dietitian, et cetera. We want to ensure that some of those individuals are available should there be questions that come up in the pre or post gene therapy phase when we're looking at eligibility and also when we're managing potential side effects should they occur. We also want to make sure we have a multidisciplinary team to address some of the possible side effects if they occur. So this may include not the typical people that you do see in those multidisciplinary team in your clinics, but additional individuals, maybe a liver specialist or a hematologist or an immunologist. So there may be additional people that are pulled in and part of the care narrative and discussion at your site. You want to ensure, again, an extensive experience in managing steroids, both in DMD, but also as related to gene therapy complications. And the emergency capacity, should it be needed, to address any potential safety or infusion-related reactions that occur either during or any reactions that could occur after gene transfer. There should also be help in the insurance support. So your administering site should have teams in place to help in handling the application for prior authorization from your insurance company. You want to ensure that you have a plan for close communication with that care team pre, during, and post the gene therapy process. And you want to ensure that there is a plan in place for how to stay close in distance to the healthcare facility, especially at least during the first few months after gene therapy, in order, again, either if it's the dosing site itself, or if you come up with a plan with your dosing site to have a healthcare facility with a hospital closer to home. And this can look different ways depending on where people live and what hospitals or care centers are nearby. Next slide. So in terms of preparing for gene therapy and what to expect, as we mentioned before, various tests will be done to look both at laboratory parameters, such as blood counts, liver function, heart-related enzymes, for example, tests that look at heart function, so echocardiograms, EKGs, potentially cardiac MRIs as well, especially in those who can tolerate doing the MRI. It's very important. Lung function and other testing. Next. Your team will also give you instructions on starting new medication related to gene therapy. So most importantly, this is going to be an extra daily dose of prednisone or prednisolone that you will need to take every single day before and after gene transfer. And you'll have careful instructions of when it is okay to wean that. This will be on top of whatever your baseline steroid regimen may be for DMD. There may also be potentially other medications that you take where the safety of that in combination with gene therapy is not fully known. And so that'll be important to discuss as well with your healthcare team. And there may be instances where a team, whether it's both for clinical trials or for a commercially approved therapy, where they may say it's best to hold or stop a medication X number of weeks or months ahead of time. And so those are going to be personal discussions, of course, on a case-by-case basis. And then finally, your team will review the risks and safety again. And this should be really multiple discussions that you anticipate having to ensure that you have all of your questions answered. Review of the treatment consent. Instructions should be provided about, again, what to expect as well as what the follow-up schedule will look like, as well as all of the emergency contact numbers of who to call and when to call in that process. Next slide. Then you get to infusion day. So important things that will happen on that day. So in the days leading up to, as well as, of course, that day as well, we always want to ensure that you have notified your team immediately of any illness. This may result in needing to delay the dosing in order to improve safety. Again, similar to the vaccination issue, we don't want to have multiple stressors to the immune system really at the same time if we can avoid it. And so we really try to ensure that the patients receiving gene therapy are healthy, are well, have not been sick, have not had recent immunizations in order to control what we can in terms of any other risks to the immune system. On your infusion day, it was on the prior slides as well related to the consensus guidelines, you will have IV lines placed. Typically, we have 2 lines that are placed and make sure that they're working well. When the drug is ready, a gene therapy product will be run as a single IV infusion, but this infusion can take several hours, up to 1 to 2 hours typically. Your medical team will be watching very carefully in that infusion space for any signs of rash, fever, nausea, trouble breathing, or belly pain that could occur during or after the infusion. And then typically you'll be monitored for at least a few hours after gene transfer. And if there are concerns that come up, potentially sites may have the ability as well to have patients admitted. Some sites, there could be variability as well in terms of how long that post-gene therapy follow-up is. And that might also differ in terms of the commercial setting versus in clinical trials. So individuals may have experienced different processes depending on the product or the scope of how it was given. Before you leave, though, you should ensure that you know how to get to the dosing site or hospital easily. If you're far away, does that mean you need to reside closer to that dosing site for a period of time? Should there be any concerns or side effects? Do you have your daily steroid dosing? And also, do you know who to call and when to call your team or when to go to an emergency room should certain concerns or issues occur? Next slide. Other key things then, once you're home after gene transfer, we want to think about minimizing the risk of picking up other infections. This means good hand washing, potentially home from school or work to avoid other sick contacts, avoiding big gatherings or crowds, making sure people who are coming over to home are well and not coming over if they're sick, and potentially wearing masks as well if the child can tolerate it in public, even when coming, for example, to their visits in kind of lobbies or busier public areas. Ensure that you can stay near your hospital or treatment site or can easily get to your hospital or treatment site for the frequent monitoring and labs. And another important point is that the virus itself will naturally shed from the body over time. This can be excreted in saliva, urine, and stool. And while it doesn't cause actual infections or issues to those who are exposed, we still like to try to minimize that exposure to other people. So you will also usually get instructions on things like wearing gloves for either toileting or diapering, good hand washing, and how to double bag waste in those especially first few months after gene therapy. Next slide. And then kind of final few slides in terms of what to expect in the post-gene therapy phase. So we'll go over a little bit on some of the safety or possible immune responses or lab changes that we might expect that could occur after gene transfer. It's important to note these don't happen in everybody, but we want to always think about what could occur and how to be most prepared. And this really ties into a lot of the lab work and those close clinical follow-ups that you'll have scheduled after gene transfer. So on the left-hand side, we have those side effects or those lab changes that can occur, especially in the first hours, days, or kind of even maybe in the first 1 to 2 weeks after gene therapy. These are part of what's called the innate immune system, and this is really a non-specific activation of the immune system. This can include fever, nausea, and vomiting. It can also, we could see some shifts in blood counts, such as a drop in the platelet counts, an increase in one of the heart enzymes, and an increase in our liver enzymes. Afterwards, starting really kind of within the first few weeks, but can go on as well for months after, what we look for is whether there are any signs of a more specific T or B cell responses that are developed, either related to the actual virus itself or to the new transgene, that is this new microdystrophin-based protein that is being produced. And so we look based on both lab findings as well as clinically. Based on the close monitoring, if we do see any signs of these, that might require dose adjustments to the immune suppression that's being used, or in some cases also admission or IV medications. And we'll get to that in a little bit as well. Next slide. So this dives a little bit more into those concepts from the prior slide. So when we talk about the safety issues and immune responses that can occur after gene therapy, this can sometimes be very overwhelming for families and can seem really scary. And so, it's important to know what are the more common things that can occur, and what are the less common but more severe that we want to always be looking for. And so hopefully, usually we don't have any, or we have minimal of the side effects. And if we are, they're on that left-hand side in kind of the purple boxes. But we always want to be mindful of how we might manage if we find ourselves in the more severe category. And again, this is really going to be, what your healthcare teams and your dosing sites are going to be working to ensure that they have those contingency plans based on the follow-up and based on potentially those additional consultants, and thinking about managing with different immune medicines if needed. So we talked about some of those on the prior slide. We could see irritation or inflammation of the liver, and that can include, again, an increase in some of the liver enzymes that can occur in the first few days, but also even around the 1 month mark or so after gene therapy. We can see just general signs of sort of non-specific immune responses early on, and this can include, again, fever, nausea, vomiting, a little less energy than normal. That's probably one of the most common things that we will see and hear from our families after gene transfer. We usually, for that, we want to encourage that the child or individual is still able to eat and drink well, maintaining good urination, keeping hydrated. And then we also can see drop or reductions in platelet counts or hemoglobin. So we'll be watching that in some of the blood counts that we're evaluating post-gene transfer. And then we can, as mentioned previously, see increases in heart enzymes, sometimes a faster heart rate early on. And again, on the more severe end of these, there can be more severe liver injury or liver failure, more severe just general inflammatory responses or changes in blood counts, or more severe inflammation of heart or skeletal muscles causing new or more exaggerated and sudden onset of muscle weakness or pain or trouble swallowing. So while some of those on the right-hand side are far less common, we do always want to be mindful about that in case there are concerns for those that you will require prompt and often emergent evaluation or admission to closely monitor and try to intervene in those situations, or to recognize potential warning signs before we get to that point as well. Possible strategies. So again, the individual, your child or yourself, receiving gene therapy would be receiving the daily oral prednisone pre and post gene therapy. But if some of these are to occur, you might have your care team increasing the oral steroids, possibly using IV steroids, Or sometimes you may find that other immune suppressing medications are used, perhaps ones that are working more specifically on B cells or T cells, plasma exchange, complement pathway. So these are really targeting different parts of the immune system. So other medicines could be used as well and have been in some instances, both in trials and also in the commercial setting. Next slide. In the healthcare guide for families, you'll also have various questions. These are, aimed to provide some talking points and to really give some ideas to the kinds of questions you may want to ask your healthcare team. This is anything from eligibility, baseline labs or studies, and what that means for the risk of treatment. What are realistic benefits for the individual specifically? Are there any interactions with current medications? What are the side effects that have been seen at that site, and how have they monitored or managed them overall? Will you need to relocate for gene transfer, and for how long? What does that look like? Who is on the care team? How do you reach them? And also, really importantly, what are the other alternatives? What are the options, and what are the risks or possible benefits of those alternative therapies? It's always important to think about both the risk and the benefit for the individual, as well as the alternatives that are available to them. Next slide. So kind of final slide here is just some important, putting all that together, some important kind of Bs, I put them. So be mindful. It's a really important decision and should never be rushed. This could mean really multiple visits or discussions, talking to different specialists, getting input from other individuals to feel comfortable that you have your answers to your questions. Be informed. Again, this might mean multiple meetings, multiple discussions. Make sure that you have had a chance to ask your questions. Be prepared. So know what side effects to watch for, know who to call, and be ready for the frequent visits and testing that will be required after gene therapy. It is really important that those do take place, and they cannot be skipped. So having a plan, whether it's help from neighbors or family, friends, figuring out time off of work or school, childcare, et cetera, to really ensure that you can get to those appointments. I know it's a lot that we ask of our families. Be diligent. So be sure to follow your healthcare team's instructions for the steroid dosing, the necessary labs and visits. It's really important for safety. Next one. Be safe. So try when possible to minimize additional exposure for other viral illnesses before or after gene therapy. This could mean quarantining, avoiding big gatherings, staying home from school, to try to keep that individual safe as best we can and avoid other illnesses during that time, pre and post gene therapy. Be communicative, so know how to reach your team. Don't hesitate to call or reach out for concerns or questions. And finally, be hopeful. There are sometimes a lot of ups and downs, and we have advances, and then there might be new safety concerns that we learn about. And really, we continue to learn every day about the benefits as well as safety or risks of gene therapy and also other novel therapies. And we're learning about this both through, ongoing preclinical, but also our clinical trial research, as well as the ongoing collective clinical experiences. And so it's continually a work in progress, but I still think there's a lot to be hopeful for there. So thank you.
Thank you so much. I really I want to share our appreciation for Dr. Byrne and Dr. Baruka Goebel being here today to share your time and expertise. If you want to take the slides down, we will go into our Q&A. It's always great to have everybody's face on the screen. We've gotten a lot of questions, really great questions. I'm going to try to kind of collate those questions, and we will do our best to get to everybody. So let's get started with our trials happening for boys who are positive for AAV vectors.
I can start with that one. Yes, there is consideration of both how to mitigate the slightly elevated pre-treatment antibodies, as well as even in the circumstances of a prior therapeutic treatment, which has even substantially higher antibody levels. Both of those programs are actively being considered. We actually have a grant from PPMD, MDA, and Cure Duchenne to address the elevated baseline antibodies using the off-label use of an already approved medication that's used in myasthenia gravis. That submission to the FDA asked first that we study this in older children and, in fact, young adults first before the younger patients who are been the most of the focus of the commercial use of Elevidys. That happened before there was a restriction in the use in non-ambulant patients, so we will have to reconcile with the FDA those considerations since we don't have access to the product for non-ambulant patients at this time, other than in the study that's being done by Sarepta in non-ambulant patients. So we can't mix those two questions together into one study, but it's actively being pursued. It has been part of studies for different indications and shown to be successful. And in fact, there's a paper that we have coming out shortly in the New England Journal of Medicine that describes a similar consideration for a disease called GM1 gangliosidosis. So this is actively being pursued. I think it's very possible that we will see this in the next year, but it's a long process to get this through the regulatory agencies. But stay tuned.
Great, thank you. We've had quite a few questions come in about research happening around getting a second dose of gene therapy. Similarly, trying to decide between those gene therapies that are in clinical trial versus those that are already FDA approved. So can you share any guidance on the possibility of second dose happening, and then just around clinical versus FDA approved?
It's kind of part B of that earlier answer. Once the first process is known for reducing pre-existing antibodies, that will be combined with another type of therapy. And there are two approaches to this that actually either transiently or in some cases permanently remove the antibody producing cells. Once those are not making antibodies anymore, it's possible to degrade the antibodies that exist. Of course, this adds complexity and will add to the risk of that kind of procedure. But we do think there'll be justification for that, because this kind of relates to one of the questions that I think we'll get to in a moment, is how does age at the time of first treatment impact the durability and the outcome? And while I can maybe make a general comment first that in all inherited diseases, if we can treat pre-symptomatically, like we've learned in SMA and through the advent of newborn screening, outcomes are improved. The challenging part in a muscle disorder is that infants who are 3 kilos that become 30-kilo children or 70-kilo adults, there's a loss of the effect because of the way muscle mass is increased over the lifespan. So while early treatment may have a very strong early benefit, it may not lead to the most durable approach unless the satellite cells that generate muscle are also treated, and the current treatments don't do that. It's possible that some of the gene editing strategies will have an impact there, and it's also possible that as part of this overall immune management strategy, it'll be possible to protect someone from antibodies developing and allow for retreatment at a second or a third time over the lifespan. So this will be part of earlier treatment that comes with newborn screening, and now 5 states are newborn screening, and this will become a huge question for the community: is when it's too early, what's the right time? If it's once in a lifetime, how do we optimize outcomes over the lifespan? Because we want to certainly be able to demonstrate efficacy and prevent what does appear that even in a 4 and 5-year-old, there are some aspects of fibrosis in the muscle that are not easily reversed. It would be best to avoid that, but we want to also make sure that this is durable lifelong. One good news, though, is at least although the skeletal muscles have this behavior of growth through adding new cells into the muscle, the heart muscle cells are permanent, just like neurons. So any beneficial effects in younger children that effectively treat the cardiomyopathy should, in fact, be lifelong. And we're actively studying that as well. We have a good cohort of kids now that are beyond 7 years post-treatment and are tracking the very detailed assessments that are needed to know what is expected from a cardiac perspective. And it looks very favorable so far in both investigational and the commercial product Elevidys. So that's the challenging part of that, is it takes a long time to get to that age where you would expect a finding for heart function, but that's actively being pursued, and why what we're talking about today is so important to participate in the registries and in the long-term follow-up studies that are being that were described in the care guideline and in the consensus document that you have.
I think I might just jump in. I know there was a second part to that question as well of, how do people make that decision between, what's commercially available, what's in a clinical trial, and there's multiple clinical trials, and so you might be choosing between trial A, B, or C. I think there's no one answer fits all. This is really going to be individuals, person specific, family specific. You want to look at, first, I think a base thing is just general safety considerations, the antibody titers, for example, whether there's a presence or high antibody to one, but are you eligible for another? Is that a possibility? I think the age might be a criteria. So for commercially proved, if it's available for 4 and older, but if there's a clinical trial that does go down to, let's say, 1 or 2 years and older, is that a consideration, for example? Or maybe in the non-ambulant individuals, are there clinical trial opportunities currently, given that's not at this moment available commercially? So I think it can be person specific to what you might be a good candidate for. Then there's thinking about the biology and kind of the actual products themselves. And it's really hard to know kind of head to head, to predict, to say, product A is going to be better than product B or product C. But I think you can look at, what is the overall rationale? They might be different in the viral capsid. They might be different in the immune suppression plan. They might have slightly different dosing or, different properties. Those should be discussions, again, you're having individually at your healthcare team and during your routine visits. If you're not fully sure you're getting as in-depth answers, you can always also reach out to the sites that are conducting those trials and potentially see if you can get additional information from those sites or investigators as well about what that trial entails and whether, for example, an individual may be a good candidate for that. Another important consideration is also where will it be dosed? I think when we're talking about how far away is it from home, how frequently do you have to be at those visits, how does that fit into family, day-to-day life, et cetera. These are all important considerations. And then also, what is the safety known for that, whatever the approach may be? What is the combined safety data and efficacy data that is available? Some of these are, again, we're still learning more about them as they're in development, but trying to just be up to date on what is happening with those and what is known so far for those. So it's not a simple answer, but just some of the things to take into consideration when having those discussions or when reaching out to different folks to try to understand what are the options on the table.
Yeah, absolutely. And you brought up some really great points for families to think about and discuss. There were also some questions that came in around any data on patients that are continuing exon skipping therapy or really any treatments after receiving gene therapy. Is there any data that you can share?
I'm not aware of data that's sort of formally available for use of exon skipping or, whether it's continuation or restarting of exon skipping. But again, to Barry's point, I think through various registry studies, observational studies, et cetera, these are the kinds of questions we hope that we can start to answer. But it really starts with having being able to have that data to understand how people are doing. Is there a need? Is there added benefit? And if so, what was that benefit? So I think we don't the actual the data on how they benefit is still limited at this time.
Yeah, and maybe I can add too that there's not a scientific reason that combination therapy wouldn't be considered. In fact, there's a study ongoing in SMA where those that receive gene therapy also have received risdiplam. It's less common that they would receive nusinersen because of the ongoing cost considerations. But in fact, that turns out to be one of the practical considerations is when insurance approves one therapy that has a high cost, would they approve a second one? And so we've had to deal with that on, at least in the context of SMA, on a case-by-case basis. And we haven't crossed that bridge in Duchenne because there hasn't been a second therapy that comes very close to the level of efficacy of the gene therapy products. Remember, we have in the single-digit percentages of dystrophin from some of the first-generation exon skipping products compared to, on average, 40 to 50% of expression of skeletal muscle cells of either wild-type levels of dystrophin or percent positive cells. So it wasn't seen to be a major contributor. Now, other products that work on a different pathway, like sevasemten or potentially givinostat or other HDAC inhibitors, could have an additive benefit, and they hopefully, as small molecules, are going to be less expensive than a second biological therapy. So it's certainly possible, and I'm sure in individual cases we'll see evidence of benefit, and that'll help make the case to payers that those combination therapies should be allowable.
And what I often will also, when having those discussions with families and patients in clinic, I mean, we also talk about if following gene transfer, if you're considering another therapy that's available, and if we can get that, approved and authorized and stuff, there's always the opportunity to really see what is the benefit and then make the decision after maybe a certain amount of time, if you really feel, and based on maybe physical therapy testing, and clinical assessment and family and patient input, whether there was, whether they felt there was an actual benefit of adding another therapy after, whether, again, whether it's something like givinostat or whether you're talking about an exon skipping or other types of therapies. So in those situations as well, there is also the potential to kind of observe what the experience is and then make a decision whether it's worth continuing really longer term, again, based on that person's experience and benefit or not from that.
Yeah, definitely. Speaking again along the lines of dual therapy, there was a question in the chat around Duvazat. I probably said that wrong. I apologize. But that nausea and vomiting is the most commonly observed side effects. And so how then will the criteria for adverse events need to be formulated?
Yeah, so I think there are a couple of things. So with givinostat, there is the risk also of decreases in certain blood counts, the platelet counts, and also if there are other side effects that can overlap with especially the side effects we're thinking about with gene therapy, we really want to be sure that we're not doubling up on some of those risks, especially in that early time points post gene therapy. So that is one of the ones where, in discussion as well, for the consensus guidelines, I think, it came into play of, are there medicines you might consider holding just because we don't know, we have limited info or really don't know the combined safety, or because the safety profile does have overlap depending on certain kinds of blood count changes or things like that
Yeah.
occur. So that would be one of those where it probably is most advisable to stop it for a period of time pre and post, and then resume it later, if
Yeah,
plans to resume.
that's exactly the policy we pursued, but it's not really covered in any official recommendation. It's really up to your individual provider, but it seemed prudent to skip the 2 month to 3 month period around the time of dosing.
Another topic here I want to switch to are the use for non-ambulatory boys. Are there any considerations for compassionate use in those situations?
There has not been an expanded access program for this product. And I think given the safety concerns that occurred, safety events that occurred, and I should point out that that was just exactly coincident with the completion of the guidelines. So ultimately, after the review, some of that information was added back, and there's ongoing learning from that. In fact, there's anticipate submission soon of a very detailed description of the 2 fatalities in the context of Duchenne. The LGMD patients not included in that report, as long as the take-home messages from the expert committee meeting that informed the revised PAC prescriber information. But I think we'll have to wait until the so-called cohort 8 study is completed. 25 patients anticipate being enrolled at 7 different sites. We're not certain how long that will take to enroll, but certainly by 6 months following completion of enrollment, there should be more evidence about how the preventative use of sirolimus impacted both the outcomes and the safety findings in the non-ambulant population. So it's probably going to take, by the time enrollment fully begins and is completed, even if there's 1 patient per week enrolled, that's going to take 6 months, and then another 6 months of follow-up. So we won't know really a lot for a year from now.
So I think if families are kind of interested in that, certainly the clinical trial, being aware of the clinical trial opportunity and enrollment, reaching out as well, perhaps when that becomes available. I'm sure there'll be probably blasts that go out to families, or updates when there are new trial opportunities. Clinicaltrials.gov is always a site that I like to keep my eye out for what what's available, or what's actively enrolling, for example, when we know trials are about to launch, or new cohorts are about to expand within trials.
Great. I know we're running a little bit out of time, but if you're able to stay for just a few more minutes, there are a few more questions. A practical question here: how long do children need to quarantine or stay out of school after dosing?
Yeah. I think this was really one where there was probably a lot of variability overall in across sites. Some who really are recommending quarantining for whether it's the first month, first 2 months, for a few weeks. I think if it's feasible, if it's an option that I would say at minimum, especially for the first few weeks, if not the first month, that's going to help get past some of those early, those periods where we're thinking about some of those early immune responses. Any immune trigger can still potentially increase the risks overall, but we realize that we're balancing this with also the complexity of life. But we do really want to ensure, as best we can, that we can minimize the infection risk. And so the longer that, if a child can stay home and it works for the family, et cetera, that's great. If it's not a possibility, then at least thinking about masking, good hand washing, et cetera. But I think at minimum, the first few weeks really are quite critical.
So I think the question also would probably pose from the standpoint of what's the risk to others of exposure.
Yeah,
and that's, we've faced this often in the context of siblings. And thankfully, there's actually been some very carefully collected data on shedding in the context of the Elevidys studies. And at least the shedding risk is probably certainly cleared within a month, probably even as short as 2 weeks, but let's say a month for safety sake. And so that's when we have siblings in the home, that's the time frame we deal with, and of course encourage hand washing and careful personal hygiene. The question Diana raised is actually maybe even more important, is the exposure to the individual who's on an increased dose of glucocorticoids may have other susceptibility to immune activation, and so we want to avoid that. So that is going to depend on the particular family circumstances, but it's probably at least a month.
Great. Well, that is all the time we have for questions, but we do want to wrap up with some additional information and resources. Again, thank you, Dr. Byrne, and thank you, Dr. Baruka-Goebel, for your time. I'm going to pass it now to Nora Capocci, who's the Executive Vice President of our Healthcare Services at MDA, and she will wrap us up.
Wonderful. Thanks, Marissa. Thank you, Katie, for popping up those slides. I'll keep chatting because I know we're already at time and roll through them and you'll get all the information. But in a few moments, you're going to see some QR codes that will link you to both MDA and PPMD's resources for you on our website. So feel free to scan those QR codes, or you can go to our web pages and look more at these. But here is some additional information for you all. And just want to thank you all for joining us today as we walk through this comprehensive family guide to gene therapy for Duchenne. And a big final thank you to Dr. Barry Byrne and Diana Baruka-Goebel for their experience and support that they have given us throughout this entire process and then leading this webinar today for us all. Gene therapy is evolving, as you've heard a lot today, and that brings us both hope and complexity. And so our goal today was to help you understand the key concepts in this guide, what your gene therapy is, what to expect before and after, the potential risks, and the many factors that go into deciding whether it's the right option for you and your family. Most importantly, we hope you feel empowered to have this information and the confident conversations you can have with your care team. As you continue exploring next steps, please remember that MDA and PPMD are here. We can provide one-on-one guidance and connection to resources, as well as direct you to other resources that are available. This webinar was recorded, and the family guide will be shared in the post email as well as be available online. And just want to say thank you again for your time, your thoughtful questions, and your commitment to learning. We are honored to be a part of your care community, and we encourage you to reach out to MDA and PPMD whenever you need additional support. So thank you all very much.
Thank you all.
Thank you.